Hi, everyone. Getting my screen sharing started here. Good morning. I'm Scott Smith. I am Associate General Counsel at the University of Utah in Salt Lake City, Utah. And this is the third or fourth year that we've presented to this group, and we look forward to it every year. And as Jared said, we give a legal update to our own School of Medicine and University of Utah Health towards the end of every calendar year, and so we're repurposing a lot of that material for this particular presentation. Our focus is on the state of Utah, since that's where we reside. We have encountered a lot of questions in Idaho and Montana and Nevada related to physician licensing and those kinds of things, so we can speculate as to what state law might be in some of those other areas, but we're most proficient in Utah law. So my presentation today is really going to look at some of the legal issues related to COVID-19 as it relates to the delivery of healthcare in Utah and the surrounding states. So going back to about a year at this time, it's hard to believe, but it's almost been exactly a year since the Rudy Gobert game, and we all realized that we were beginning a pandemic. So the first thing that happened that we all understand, but that's interesting to note, is that federal and state emergencies were declared. And these aren't just perfunctory or political, these are critical because in order to access emergency funding and in order for the government to have authority to waive certain legal requirements, those are preconditioned upon these emergency declarations. So for example, in the state of Utah in early March last year, Governor Herbert declared an emergency. And then on the national level, President Trump declared an emergency, and that was followed by a similar FEMA emergency declaration. And we would expect in your states, Montana, Nevada, Arizona, Colorado, California, that there would be state declarations right around the same time in March of last year. One of the first big tasks for healthcare administrators and healthcare attorneys after the pandemic started was trying to understand all of this state and federal legislation that was occurring. And what we've outlined here is a lot of the major COVID-related funding opportunities that occurred on the federal level. And we'll focus mostly on Relief Bill number 3, which is called the CARES Act. But initially, about a year ago at this time, the federal government set aside some money towards vaccine research and development. Then a few weeks later, there was a second relief bill, which you might remember. This one was sometimes called the FFCRA, or the Families First Coronavirus Response Act. And the most interesting thing about this piece of legislation was that it extended family medical leave for people who needed to be at home to take care of their kids once school got canceled or once school went online. So there were some provisions to what extent could employees have additional leave to take care of their children once school was canceled. Shortly after that, the third bill was passed, and this is sometimes called the CARES Act, and this is where most of the action has been for healthcare providers throughout the country. What this did, this was the bill that gave ordinary Americans cash in their pocket. It dramatically increased unemployment coverage around the country. This instituted the Paycheck Protection Act, which is loan forgiveness for small businesses. And then there were a multitude of healthcare related stimulus programs, which we'll talk about. There later was a fourth stimulus, and then as recently as December of last year, there was a fifth stimulus bill. And so now with President Biden in the White House, the bill that's now being discussed is the $1.9 trillion stimulus. That's in fact the sixth COVID relief bill. So it'll show up in this outline eventually as we go forward. And that bill is expected to mostly focus on unemployment, cash in the pockets of ordinary citizens, money for tribes and state governments for COVID reimbursement, vaccine reimbursement, but we're keeping our eye on that to see what components might relate to healthcare entities. So focusing again on the CARES Act, which was the third bill, you've probably seen this at your hospitals or medical centers. The main bucket of money that impacted hospitals was this provider relief fund, which was sort of a subset of the CARES fund. What this said was that hospitals could be reimbursed for COVID-related expenses or for lost revenues attributable to COVID-19. So if you had loss of business, loss of RVUs related to COVID, or expenses for PPE, testing facilities, extra security, extra police, all those kinds of things could be reimbursed through the federal government. And this process, you have to apply for, and then you have to audit your records to show that the money that you've saved or been reimbursed for corresponds to your expenses or lost revenue. And this was certainly an important source of funding for our hospital here in Salt Lake City. The second thing that you no doubt recognized was that the federal government, without hospitals even having to apply for it, they accelerated a lot of the Medicare payments. So obviously the government could estimate based on the prior year how much Medicare money you would be expected to receive in a given year. So they just fronted that to a lot of hospitals last April, May, June, with the idea that hospitals would sort of pay that back throughout the remainder of the year by not being reimbursed because they had already been reimbursed in advance. Then for higher ed institutions, there was some other money for student relief, artistic organizations, and those kinds of things. The area of EMTALA is interesting to me because it's an area where I've practiced most of my legal career here at the university. And you all know EMTALA is the law that prohibits emergency rooms and urgent care centers from turning patients away based on ability or inability to pay. And one of the interesting things that occurred immediately after the emergency declaration was the federal government became very flexible on EMTALA. So you see in the photograph here, these testing tents, and a lot of your hospitals set up these testing tents or even set up testing areas in parking lots that were away from the main hospital. In normal times, these would not be permitted under EMTALA because they would sort of extend the emergency department out past the building, and you would then be required to have, stabilization and normal emergency medical care in these tents, not just COVID testing. But the government allowed flexibility so that hospitals and clinics could set up these testing centers without taking on the responsibility of having to have all of the emergency care that's normally available in an ED available in these tents. And this is just temporary during the CMS waiver during the pandemic. And just one point on that, presently the federal emergency extends through April of this year. No doubt if cases are still high, President Biden will extend that. But as of right now, the emergency extends till April. In the state of Utah, the Department of Health has extended the emergency until, was it June of this year, Haley?
It's TBD, but yeah, they're the kind of the soft target is June.
And we would expect that to be similar in the other Rocky Mountain states. Of health mandated with sort of a TBD on those. So presently we are all under these EMTALA waivers. The other thing that occurred that really impacted your hospitals and our hospital was there was a lot of flexibility that occurred in the area of telemedicine. So as you know, normally if one of our doctors here in Salt Lake were seeing a patient in Idaho, our physician would need to be licensed in Idaho. Most of the states in the Rocky Mountain area became quite flexible with state licensure so that physicians in Idaho can see patients in Utah and vice versa without needing licensure in those other states. So it's dramatically expanded the provision of telemedicine across state lines without needing licensure in those other states. And this is all currently expected to be temporary. In other words, when the pandemic ends, we believe that the states will revert back to the status quo, meaning that, the Utah physicians now providing telemedicine care to Idaho patients will either have to stop doing it or get licensed in Idaho, and vice versa. The other thing that occurred was CMS and different payers started reimbursing at a better rate for telemedicine. And again, totally up in the air to be determined whether those rates will continue after the pandemic ends or if they'll try to pull back. But this has been a dramatic change in the delivery of healthcare throughout the country. One of the topics I know you're interested in has to do with employees and the Americans with Disabilities Act and COVID-19 safety precautions. So we were fortunate, all of us, in that after the pandemic occurred, the federal government issued some guidance through the EEOC that was fairly clear and actually quite helpful related to this topic. And what they said was that during a pandemic, employers can do all of the things that I have listed here. So they can require face coverings, they can perform temperature checks, they can require employees who are infected to stay home, they can require a doctor's note for return, they can mandate COVID testing, and they can otherwise screen for COVID testing by asking questions. In that guidance, the EEOC did not go so far as to say that employers could mandate a vaccine or a test. And that's where we still are today. In the state of Utah, there's a number of bills pending with the state legislature now that would prohibit employers from requiring a vaccine. I would anticipate that Idaho especially probably has similar laws pending, and they seem to be popular among the public. So I would be surprised if some of those laws didn't pass that would essentially prohibit at least state employers from requiring vaccines at this time. So where we sit here today, I don't think in the short term, I don't think employers will have the authority to mandate COVID testing before returning to work, and definitely not public employers. Maybe some private employers will. We know, for example, like the NBA, NFL, they have these testing schemes, but by and large, I don't think that large hospitals and public employers are going to be able to mandate vaccines just yet. In talking with some of our infectious disease folks, the way this normally works is, once the vaccines are commonplace and well understood, and once there's more data, this will eventually become similar to a flu shot where, a year or two from now, you could imagine this would be part of the mandatory vaccine package to work at your hospital with MMR, Tdap, flu, and the other vaccines that folks get. Right now, there's not enough water under the bridge yet to where there's really going to be enough kind of medical outcry to get a mandate. So again, where we sit here today, we're probably not in a position to mandate vaccines for folks that come to work, but we are in a position to mandate all of these other things. But we'll keep a close eye on that. And then HIPAA comes into play. HIPAA permits hospitals to notify public health oversight entities of contagious disease status. And so there's been a large flow of data from all of our hospitals to the public health departments regarding COVID testing, which is pursuant to HIPAA. And then some of you, if you're connected to a school or another employer, some of that's done through consent, like here at the University of Utah, all of our students, in order to return to campus, had to consent to testing from time to time. And then one final thing, and again, you could email me or Haley, and if we have information that's handy, we're happy to share it with you. We can't give you individual legal advice, but if we already have something, we're happy to share it with you. But Utah passed this law last year that was very helpful, that said that employers and people that own property and buildings could not be held responsible for people getting COVID on their property. And the chief sponsor, Kirk Colmore, he practices in the area of landlord-tenant law, so this is a very kind of landlord-friendly law. But essentially, this gave a lot of businesses in Utah a lot of comfort that they could reopen their restaurants, their businesses, their universities, and so on. And that if somebody got sick on your premises, you could not be held responsible for that unless the victim could show, intent or gross negligence or recklessness. So, and again, I don't know if we have similar laws in the surrounding states, but you can certainly send us an email, and if we're aware of something, happy to respond, even though that wouldn't constitute legal advice per se. But this has been a huge help to businesses in Utah to feel comfortable providing commerce during this particular time. So I'd be surprised if the other states didn't have the same thing. And now Haley will take us through some of the more specific pieces of legislation on the state and federal level.
All right. Well, thanks so much, Scott. So like Scott said, my name is Haley Ritchie, and I'm going to talk about some of the changes that we're seeing at the state level and at the federal level as a consequence of the 2020 general election. So I'm sure you've heard, at least for those of you in Utah, that we have a new governor and we have a new lieutenant governor, Spencer Cox and Deidre Henderson. They won the governor's race and the lieutenant governor's race and began their 4-year term on January 24th. And with the legislature this year, all of the House seats were up for election, and 15 of the Senate seats were up for election. And perhaps unsurprisingly, the Republicans were able to maintain their majorities, in fact, their super majorities in both chambers. So what are some of the things that the Utah legislature is considering discussing? Well, unsurprisingly, the leading topic, if not one of the leading topics, is the state's response to COVID-19. So for example, as it relates to some of the federal COVID relief funding that we've seen come through Congress, if Congress were to pass another relief package that were to give the state additional funds, the legislature would actually need to review and give its approval before the state can formally accept those funds. So this is because Utah has a law that generally requires legislative approval of these sorts of significant federal funding streams, like the ones that we've seen throughout the pandemic. Another issue that's really top of mind to the legislature, especially this week, quite frankly, relates to emergency powers and the appropriate roles of the legislature, the governor, the Utah Department of Health, local legislative bodies, and local departments of health. Over the past year, several legislators have voiced concerns that Utah's Emergency Management Act was drafted with an eye towards short-term emergencies like earthquakes, floods, that sort of thing, as opposed to long-term emergency management, such as what's been required with the COVID-19 pandemic. And so the legislature is currently debating questions like, can the governor renew an emergency declaration after 30 days? Obviously, Governor Herbert took the position that he could do that, and he did do that on several occasions, but the legislature is going to weigh in here and clarify exactly when that can happen. Similarly, the legislature is addressing questions like, can local legislative bodies modify or revoke public health orders that are issued by local departments of health? This question, of course, arose in Utah County when leaders there imposed a mask mandate. Aside from COVID-19, but related to it, mental health and substance abuse disorders is another topic that the Utah legislature, and I suspect other legislatures in other states are continuing to address. As you know, our medical experts have been warning about a so-called second wave of mental health and substance use disorders as a result of the pandemic. There's some rather concerning statistics on this slide, but they're basically saying that the massive scale of interpersonal loss that we have experienced as a result of COVID has really been compounded by the societal disruption that's been necessitated by, unfortunately, the mitigation strategies that we've needed to adopt to respond to the pandemic. So social distancing, physical distancing, the quarantine measures, all of that has made it really difficult for folks to cope and fundamentally change the way that we have coped with the pandemic. And so the legislature, again, is going to continue to think about how can we support mental health risk assessment and screening? How can we increase healthcare access for those at highest risk? Another evergreen topic that the legislature is discussing right now relates to medical cannabis. So for example, legislators are looking at the registration process for physicians and for APRNs and for PAs to register to become what's known as a qualified medical provider. These are the folks that are authorized to recommend medical cannabis. There's currently a bill before the Utah legislature that would create this new category of providers called a limited medical provider. And they're basically providers who recommend cannabis to a limited number of patients, so fewer than 15 patients at any given time. There's also bills that talk about qualifying conditions. So increasing the number of conditions that a patient could have to obtain a medical cannabis card. Who can access the electronic verification system, which is basically the electronic infrastructure that backs this whole system. And then what information, if any, should go into the controlled substances database about patients who access these sorts of treatments. What else? Well, the legislature has been very busy. Everything on this slide and much, much more is before the Utah legislature right now. So everything from professional licensing to civil commitment to pharmacy and PA practice is on the table. It's been a very, very busy session, and there are 9 days left in the session, and they're shaping up to be very, very busy ones. There's tons of policy making left to do, and I'm sure they'll do it. So what's been going on at the federal level? As you know, the American electorate selected Joe Biden and Kamala Harris to replace President Trump and Vice President Pence. They started their term on January 20th. But before I talk about some of the policy proposals that they're pursuing, let's talk a minute about the transition and what's happened over the last several months. So after the election, a lot of individuals were referring to President Trump as a lame duck president. But the reality is he had a lot of power and a lot of tools to impact US healthcare policy. So for example, he could still issue executive orders. And if history told us anything, it told us that President Trump would release a lot of executive orders at the end of his presidency. So those presidents who issue a lot of executive orders at the front tend to do it on the back end, and that's exactly what happened with President Trump, especially where he was being succeeded by a member of the opposite party. So he ended up issuing about 23 executive orders in his term. So overall, trending above his peers that took office before him. In addition to executive orders, there was a lot of midnight rulemaking, or what some people call the Cinderella effect, going on, where bureaucrats in President Trump's administration really rushed to finalize the rulemaking that they had been engaged in during his term. Again, not atypical, something that often happens. Saw a lot of that. But of course, when President Biden took office, he then had the power to issue executive orders. And in fact, as of today's date, he's issued 31. So he's actually trending above President Trump in terms of the number of executive orders that he's released. That said, most of these executive orders have been aimed at reversing the executive orders of the Trump administration. We'll see what happens, but again, it looks like he's trending just as President Trump was, or at least, or potentially higher in terms of the number of orders that he's issued. Also in keeping with the actions of previous presidents, on day one, President Biden issued what's called a regulatory freeze memo, which basically imposes a moratorium on any new rulemaking, and it suspends or postpones the effective dates of final rules that are not yet in effect, and it withdraws proposed rules. And in a nutshell, the goal of this sort of freeze is to ensure that the policies from the previous administration that the current administration doesn't like don't continue. And then finally, you probably heard this week, there's nominations for President Biden's cabinet, and particular concern or interest to us. The HHS secretary, I think, is testifying this week during his appointment process. So we'll see what happens there, but obviously a very key policymaker for all of us who track healthcare policy. In terms of what President Biden can do and Kamala Harris can do in terms of furthering their policy agenda, it's obviously going to be very heavily influenced by the makeup of the new Congress. So as you know, during the last election, the Democrats were able to maintain control of the House, and they regained control of the Senate. You might be asking yourself, how could Democrats possibly control the Senate when all they have is 50 seats and Republicans also have 50 seats? Well, this is all driven by something called the filibuster. The term filibuster is actually a Dutch word meaning pirate, and it occurs when a senator attempts to block or delay Senate action on a bill or another matter. So under the Senate rules, a senator or a group of senators can speak for as long as they wish and on any topic that they choose, unless 3/5 of the senators, that's 60 of 100 senators, vote to bring the debate to a close by invoking what's called Rule 22, or the cloture rule. And because of the threat of the filibuster, 60 votes are basically required for every single item that goes before the Senate these days. What happens is after the cloture vote, debate's limited to 30 hours, at which point they take a final vote, and that final vote only requires a simple majority or 51 votes. But wait, they don't have 51 votes, do they? Well, they do, because of Kamala Harris. So as you probably know, other than being the president's successor in times of death, resignation, or removal from office, the vice president's only other constitutional power is to preside over the Senate. So she's going to be the tie-breaking vote when this happens. She'll be able to get the Democrats the 51 votes that they need to push through any legislation, especially legislation that's controversial, like significant healthcare reform. So just a quick note on Utah's delegation, we actually have 2 new federal delegates, Representative Blake Moore in the 1st Congressional District, and then Representative Burgess Owens in the 4th Congressional District. They replace Rob Bishop and Ben McAdams. All right, so what will President Biden and the new Congress tackle this year? Well, in addition to COVID, I think we're going to see the administration pursue several Medicare proposals. I'll note that President Biden's position on Medicare has shifted over time, but recently he's been advocating for a public option for Medicare, which would basically be a federally backed plan that would be offered alongside the private plans on the marketplace, and anyone would be able to enroll in the public option, even if they had access to affordable coverage. And then all healthcare costs would be capped at 8.5% of an individual's income. Biden's also in favor of repealing the so-called non-interference clause, which prohibits the federal government from having a direct role in negotiating or setting drug prices for Medicare Part D. And he's also said that he's in favor of lowering Medicare eligibility to 60 so that folks could enroll 5 years earlier than under current law. From a Medicaid perspective, Biden has also said that he would like to have some sort of a public option for Medicaid. This public option would be premium free, and it would allow individuals who lack coverage because their states have not expanded Medicaid, which those states are listed in orange on this map. Those states that have expanded are listed in blue also. But Biden would basically allow expansion states to move their expansion population to the public option as long as those states continue to pay their current share of the cost of covering those individuals. Biden's also in favor of increasing the federal percentage of federal aid. So this is the federal medical assistance percentage, or FMAP, which is provided to states to boost coverage under Medicaid. So as you know, FMAP varies by state and averages about 50% across the nation. That is, the federal government pays 50% of the program's costs and the state pays the other half. Several groups are calling for the FMAP to be increased to 100% during the pendency of the public health emergency related to COVID. That is, the federal government would pay 100% of the costs. Sounds like recently Biden has mentioned that he's in favor of that. Over the last 4 years, we've heard a lot about block grants and work requirements for Medicaid. Within the past week or so, the Biden administration has said that that's a no-go. They're going to revoke requirements related to related to work requirements that have been approved in existing waivers, and then they're going to deny any waiver requests that ask for those sorts of requirements moving forward. What else? President Biden has big aspirations for surprise billing, substance abuse, drug prices, mental health. I think the surprise billing piece has largely been taken care of in the Consolidated Omnibus Appropriations Act, which Congress passed at the end of December, which has several provisions related to surprise billing, but it wouldn't surprise me if they continue to tinker in this space. So we'll see what happens in the next few weeks and months. And then I'll just close by noting that we still have the outcome of the California v. Texas case kind of looming in the background. As you'll recall, this is the case that put simply, is challenging the constitutionality of the individual mandate and more broadly, the entire Affordable Care Act. And it's quite obvious for me to say that if the court were to strike down the Affordable Care Act in this case, it would fundamentally and significantly impact just about every single aspect of American healthcare. So everything from how insurance companies treat individuals with pre-existing conditions, to the scope of states' Medicaid programs, to CMS's pilot innovation pilots, to how much seniors pay for drugs. So it could be a profound impact. And of course, if the court were to take that action, I think Congress would then have to try and cure the constitutional defect. And they could do this by repealing the individual mandate, passing a law that says the mandate is severable from the rest of the ACA, or probably the most difficult option would be to come up with an alternative, something that Congress has not been able to do to date, but maybe they would be able to do with a majority controlled in both houses by the Democrats. So we'll see moving forward. And with that, I'll turn it over to my colleague, Brian Watts.
Brian, I think you're muted there, your microphone.
Thank you.
Yeah.
I think we might have a little bit of time at the end for questions. I'm just going to talk for about 10 minutes or so regarding data privacy and security issues, and in particular, the University of Utah's experience in 2020, which was unfortunately a quite active year for us in this space. So to begin with, I think this is, I say it's a brave new world, but we're getting increasingly comfortable or growing comfortable with our discomfort at how scary it is in the cyber security field right now. You can't go even a day, it seems like, without some major headline about a significant security breach. Malware, ransomware, of course, is becoming much more of a concern. The University of Utah, unfortunately, suffered a ransomware attack in 2020. We were fortunate that took place outside of our health system, outside of our HIPAA-covered entity. But obviously, you can see the disruption and concern that an attack like that can cause. And what I'm going to focus most of the time today on is phishing attacks. Because the university also suffered a handful of phishing attacks this year, or 2020, I should say, and want to talk about our experience with that and then just some lessons learned. So to begin with, this we deal with this not just in our professional lives, but also in our personal lives. So I think people are familiar with this technique that is being used by bad actors out there. There's really two kind of broad categories of action. One is phishing, which is really not targeted. They cast a very broad net. They send information or messages to a huge swath of people, and they hope that they get 1 or 2 bites. And I'll show you some examples in just a moment, but they really are improving in terms of their ability to get people to interact with the content that they're providing. And they do this usually by having some sort of emotional response or trying to get somebody to make a quick decision with respect to content, and links. So hyperlinks in email messages that will disguise, you don't see, the obviously fraudulent content until you click on a link that takes you to somewhere where it's too late. And the abilities to spoof email addresses, to mask their true origins is continually improving. The days of obvious, grotesque spelling errors and things that were just obvious tells, unfortunately, is moving into the past. So it requires much more vigilance on the part of end users. And then spear phishing and whaling, these are attempts that are more geared in kind of the, a targeted social engineering type of manner, where individuals will identify names and positions of key individuals. They'll try to mimic identities and try to get, they're much more targeted in terms of trying to extract information or access from particular individuals. So, with that, here are some actual examples that the University of Utah has seen, and this is a classic example of a phishing attempt. So again, referring back to the emotional response aspect, this is it's urgent. It has something to do with your budget. I think that it's natural that people instinctively are going to be concerned and want to understand what's going on with that. But again, you see there's a link, and that link takes you to a malicious software that can access the computer. Again, here's another example where you can see that people are a little bit more targeted. But again, trying to get an individual to interact with the content or provide account information or other information that a bad actor can use to cause trouble. And then this is one that I believe I actually used or that I received. And you can see here, USHE, this is the Utah System of Higher Education. This was not an email that was actually from that group, but people are able to spoof email addresses. So it's increasingly looking like content is from a trusted source, which just increases the likelihood that you're going to click on a link and get yourself into some trouble. So I think we traditionally think about, when we think about data breaches and HIPAA in particular, we think about the electronic medical record, we think about these institutional systems, and we don't think about our email, and we think email is just how we're communicating day to day. We don't have sensitive information there. And so you're cheering like this happy woman, but then you realize that people are emailing around protected health information. When I talk a little bit more about the experience that we had, we found that it was common for people to be using Excel spreadsheets and attaching those to emails. So you have one email, but with one attachment, you can all of a sudden have one email communication that implicates hundreds or thousands of patients. There's also, on the philanthropy side, you may have information about donors, discussing donations, account numbers for banking, research and intellectual property, trade secrets, business plans, etc., and then sensitive information about employees. So to the extent that people feel like email is a lower risk system, you need to get out of that frame of mind. I'll talk about efforts to minimize the risk associated with email communication, but I think you need to prioritize email as one of the systems that you need to care the most about in terms of your systems. And this is what you look like after you realize all this, of course. And as alluded to before, I mean, with all the activity in this space, it's not a question of if there's going to be an issue, it's just a question of when and what you can do to mitigate. So with the University of Utah's experience in 2020, we had 19 email accounts that were affected. All of those were phishing there was one that included a malware component, but by and large, these were phishing campaigns. And the university was never able to confirm that data was actually exfiltrated, but we did determine that accounts were compromised or were vulnerable to compromise. And under the HIPAA standards, when trying to assess whether or not a breach occurs, the regulations really put a heavy burden on HIPAA covered entities to essentially prove that no information was taken or misused, which puts covered entities in a difficult spot of having to notify or go through breach notification processes when really it's uncertain whether or not anything has actually been compromised in the way that normal people in day-to-day life would use that term or think about it. But in these cases, as you know, I mean, whether you're talking about 2,000 patients or one, if you've got a breach that meets the standards under HIPAA, you have to notify the patient that's affected. If you have and you have to notify the federal government. If it's above 500, you have to notify the federal government within 60 days instead of just annually. And then you also have to do some public notification efforts. So this was a big, heavy lift on the part of the university staff that were involved. We had 4 incidents over the course of several months that we reported to the Office of Civil Rights, and also did public notifications as well. And then I alluded to the ransomware attack that got some press in 2020 as well. That was a situation that affected our College of Social and Behavioral Sciences. Again, not part of the U of U health structure, but it was very instructive in terms of how to react and go through a process where you've suffered a ransomware experience. So the phishing, even if you just have one person, this is what makes it so scary, is, I mean, the old cliche is the chain is only as strong as the weakest link. And while there are some good IT security initiatives that can be put in place, and I'll talk about what the University of Utah has done in just a moment, really one mistake can cause catastrophic results. So probably the most famous healthcare related breach relates to the Anthem Blue Cross Blue Shield in 2015. As that has gone through the process, there's been quite a bit of post-mortem that's been done on the experience. And the conclusion was that this whole incident could be traced back to a single phishing email that was opened by an employee within an Anthem subsidiary. That resulted in exfiltration of close to 80 million unique user records. And what happened is once they got access to one account, those credentials can sometimes be used to get into institutional systems. If you're using the same username and password for email as you are for other systems, and there are no additional security hurdles. Ultimately, the theory was that the bad actors here accessed at least 50 individual accounts, and then were able to gain access to around 90 institutional systems within Anthem. Anthem paid the largest ever HIPAA fine in the wake of this, to the tune of about $16 million, and then settled a bunch of state law class action claims for about $48 million, and committed to over $200 million of expenditures to improve the security protocols. So this is, an extreme example, but not one that is unrealizable in terms of real life experience. So there are a couple of developments very recently that I think are helpful to HIPAA covered entities. One is the Office of Civil Rights and Health and Human Services, which enforces HIPAA. They've backed down from a more aggressive interpretation of their fine authority, such that they were, depending on how you look at it, they were getting around annual caps on total HIPAA fines. So HIPAA fines they're complicated. They're based on numbers of violations and the culpability of the entity, and at least in the eyes of the agency. But in this, and these revisions to the HIPAA fine structure are directly related to the OCR's efforts with MD Anderson in a case that remains in the courts. But originally, OCR fined MD Anderson over $4 million after conceding that their approach to their fines was not supported by the statutory text. They reduced that fine amount to about $400,000, $400,000 to $500,000. And then just recently, I think last month, the Federal Fifth Circuit Court of Appeals issued a HIPAA opinion that is going to be very interesting to watch, because in many ways it decimates a lot of OCR's core arguments and the foundation of how they enforce HIPAA. In that case, MD Anderson had 3 situations where they had devices, thumb drives, for example, that contained protected health information that were not encrypted, and the thumb drives were stolen or lost. The Fifth Circuit basically said that MD Anderson had complied with HIPAA because HIPAA had said that covered entities must have a mechanism to secure the data. And the Fifth Circuit said, well, they did have a mechanism. They handed out encrypted thumb drives to all their employees. And it seems crazy that you would hold an entity accountable if they get it right, 99 times out of 100, but their system fails in one case. They also criticized OCR for inconsistency in terms of how they approach different fact patterns and the fines that they impose on covered entities. And anybody who's worked in this space, this has been kind of a point of some confusion, because you look at OCR notifications of breach events, and corresponding fine amounts. And it does seem quite uneven. I mean, you see similar fact patterns where there's a significant fine in one case and maybe no fine at all in another. So we'll see what HHS does with this Fifth Circuit opinion, if they try to get a Supreme Court hearing, or maybe they'll request en banc a full hearing by all the judges on the Fifth Circuit to try to get this changed. Failing that, I think that you'll see OCR in a position where they feel compelled to do significant revisions to the regulations that they've promulgated under HIPAA. So that, that's kind of late breaking legal news in the last month or so on the HIPAA front, but going to be very interesting to see what happens. I should note the Fifth Circuit decision, Utah is in the 10th Circuit, so that decision is not binding on the 10th Circuit, but it is certainly going to be one that other federal courts will look to heavily, because it just directly confronts some of these issues in a way that will be difficult for any future court to ignore. And then just in closing, I mean, what we ended up doing at the University of Utah, we use a dual authentication security protocol for a lot of our systems, and we expanded that to email. So it was certainly it caused some growing pains as we were rolling it out. But at the end of the day, for these phishing attacks, the dual authentication is proving to be the most attainable and the most effective way to combat it, because again, getting credentials alone is not going to be enough. There's going to have to be some sort of access to a device that is associated with the end user, which makes it much more difficult for systems to be compromised, although it's certainly not foolproof in and of itself. And again, this is a hassle. I mean, I think that there's been some complaints and there have been hiccups in terms of the rollout. It is definitely a change. It's an additional step. There's hassle factor. But at the end of the day, I think when you can implement changes like this, more often than not, you're getting enough bang for your buck to justify it. So in terms of how you can approach these things, I mean, again, what we've learned is that we've gone through an educational push to really dissuade individuals from using email as a primary source of moving especially large amounts of sensitive information. So we have an internal HIPAA compliant cloud storage service that we're encouraging people to share access to spreadsheets, for example, through that type of mechanism. The other thing beyond, phishing attacks, all it takes is wrong auto-populate for a recipient of an email, and you've inadvertently sent something outside of the system. So the more that you can leverage tools that are internal to the system, the better off you'll be. And then it really requires people to start from a state of suspicion. I hate to say it, but trust your judgment. If something seems weird about an email, even if it looks like it's from a trusted source, pick up the phone, call the individual, make sure that you're seeing something that's legitimate. And then the tried and true, never share your password. Increasingly, there's no reason for anybody to be requesting access to your password. There are ways to auto reset that and get access if needed. So these are just some ideas. And again, we have no idea what the next 5 years will hold in this space, but it is constantly evolving, and it's becoming increasingly important to put a lot of emphasis on efforts in this field with your entities.